pleasure to be here this morning, and I'd like to thank the Cornea Society for asking me to give this talk, and I'd like to thank all of you for getting up early to come in and hear it. My two co-authors are Matthew Fang and my wife, Mary Ann. There we go. No relevant financial disclosures except for Bosch and Loam. Now, endothelial keratoplasty is a disease-specific surgery relative to PK. We only replace the dysfunctional part of the cornea, and we get better visual results in PK, and it's safer for patients. And as this evolves, we've gotten more precise, transplanting less tissue. Now, the early attempts at endothelial keratoplasty all failed. George Tillett reported this in 1956. Jose Barraquer talked about it in 1980. But early on, all the doctors used sutures to put this posterior graft on the cornea. And if you think about that, the way the cornea is curved, if you put a suture in it, you're going to pull it tight and straighten it, and it'll come off the back of the recipient, and that's why it didn't work. Buddy Culbertson built on the things that Barraquer did and actually tried a technique where you did a microkeratome first, tree-fined the posterior cornea, and then replaced that part. And that actually worked in patients, and patients saw. But really, this whole thing took off with the insight of Garrett Mellis when he realized that you could just put air in the eye and the surface tension would hold the donor cornea in place without sutures. And it all took off from there. And Garrett did a number of other things that really advanced this. He had the idea then that you didn't have to dissect a pocket on the back of the recipient cornea. You could just strip Decimase and put the donor right up on the back. And then he realized you don't even need stroma. You can just do Decimase and endothelium. And those have been our big advances that we had. This is one of Garrett's early pictures showing how we would do the hand dissection to dissect the posterior stroma. You'd get that dissection plane, then you go in with scissors, cut it out, and then you'd put your donor in. Obviously, it was not an easy surgery. This is a picture of what one of those looked like. You would tree-find the donor, but sometimes it would be larger than your pocket, and you might have an edge stick out like on the left, or you might have an edge tucked in like on the right. When we started doing dissect, Mark Gorvoy came up with the idea that instead of doing a hand dissection, we could use the microkeratome. He renamed it Dissake. And with that, it really made it much easier for everybody to get reliable surgery and good results. Now, if we review the three ways that we can replace the endothelium, we can do a full thickness graft, a dissect with some stroma, or Decimase and endothelium only in DMEC. And this evolution has been very similar to the evolution that we've seen with cataract surgery when we went from intercap to extracap to phaco. As we get smaller incisions, we get better vision and safer surgery for the patient. In fact, now many of our patients are 20/20 to 20/40 corrected vision on day 5, and a number of our patients are now opting to have their second eye done 1 to 2 weeks after the first. That is a huge change for transplant surgery. Now, there's a myth in DMEC that the donor prep is the limiting factor that keeps surgeons from doing this, and it may be in their mind, but that's a myth, because if you look at any of the reported series now, for surgeons that do their own donor preps, the donor loss rate is less than 1%. Early on it was higher, but as we've refined our techniques, we can do this better. The limiting step is really positioning and unfolding the donor, and this is the fun part of surgery. Now, we began using a slit beam to be able to determine which way it's folded. It always curls endothelium out, so what you want to see is a configuration like an A, and when you shine the slit beam across that, you'll see the two little humps show up, as compared to if it's the wrong way, you just get one continuous one where it's folded endothelium up. You can even do this with intraoperative OCT. This is one machine that's approved now. And here's another one that's out that you can actually get this view through your oculars. You don't even have to look away. And what I've done here is superimpose the picture at the same time. This is similar to what you see in the ocular. On the left-hand side is a slit beam showing you which way it's oriented. This is a 44-year-old donor. And on the right, you can see the two cuts, the vertical and the horizontal, going through the folded donor. And what's really neat about the OCT, you can actually see how it's multiple folds in there. Now, where are we going to go in the future? I think Dr. Kinoshita has really been the leader in this area. A lot of places are looking at cell cultures. He's already injected cells, he now has said, in 11 patients. and they've looked at ways of even doing it without injections, where you might put it on a carrier, and we're going to need long-term data on this, but I think this is where we're really going. And for some patients, we may be able to just stimulate the growth of the cells either with topical drops or with injections into the anterior chamber. But you know, the most important evolution, I think, in endothelial keratoplasty hasn't been the fun surgery we get to do, but our improved understanding of cornea and glaucoma, and that's what I want to talk about now. But first, let's go back 10 years ago to the World Corneal Congress in 2005. You may remember the cherry blossoms in Washington, D.C. When I looked over the program, there was one invited talk on DELEC, 3 papers on DELEC, 1 free paper on the ELK technique, and 1 free paper on DESEC that I gave. What a change in just 10 years. At that time, Moria did a wet lab on DESEC, and I think that was the big tipping point. We had 200 or 300 people come to that, and that's really when everybody started looking at endothelial keratoplasty seriously. By the end of 2005, EK only represented 4.5% of the grafts in the US. It's now well over 50%. And like I said, it's a huge change in 10 years. In 2005, I think there were also some givens. These were Goutte don't decrease vision, only edema does in Fuchs dystrophy. If someone has Fuchs, you should try to do a cataract, delay the transplant as long as possible, have them use a hairdryer. You should wait a year between grafting each eye. Young donors are better than old. For rejections, we thought the endothelium was the most important part of the cornea for immune recognition. And if someone had glaucoma, we assumed they had poor vision and outcomes for their grafts. And there really wasn't much difference between trabs and tubes. They were both okay. And short-term problems, but no long-term problems with either one. Well, let's look at Goutte first. This is someone that has Goutte. We all know what that looks like. This is Latin for drops or bumps on the back of the cornea. And traditional teaching is that Goutte don't matter. But our experience with DEMEC is that Goutte definitely decrease the quality of vision. They decrease color perception as well as your appreciation of detail. And if you have edema, we think that leads to possible loss of the stroma. We've reported on that. And Sanjay Patel has talked about the long-term degenerative corneal surface changes that happen, and that's probably, I think, from the edema. Now, look at this patient here. There's a little haze in the center. You think it might be edema, and you get this ground glass appearance, like on a bathroom window where you don't see well. And I'm going to show stripping this, and any of us that do stripping where we do a cataract at the same time and have a good red reflex will have seen this. But look at how that red reflex changes when we remove decimase. Decimase isn't clear. I think it's just really thin, and it's semi-opaque or opaque. But as we remove this, the view gets much better. And so I think the big change here has been that Goutte do matter. And in Fuchs, if you want someone to see well, you can't just do cataract surgery. You have to also remove the Goutte. So this is a patient I saw in 2008. Told her she shouldn't have LASIK because of her Fuchs. She came back to me 2 weeks ago. In December, she had a multifocal lens. You know what? She's not seeing well, and the reason is the Goutte. She doesn't really have edema, but the Goutte distort the image significantly. So in our cataract patients, if they have a lot of Goutte, you need to replace the cornea, and with DEMEC, there's no reason to delay grafting. We've done over 1,800 DEMEC cases in our practice since 2008. We still only have 20 documented rejection episodes, and 2 of those have led to graft failure. All of these have happened after stopping the steroids. We've seen rejection lines and such. So rejections happen, but they're really rare. So let's look at these 3 ways to transplant the cornea again, because they all affect the way that we get rejections. We did a study where we looked at the cumulative rejection rate between PK, DESEC, and DEMEC. And what's important about this study is all the groups had the same steroid dosing, and they all had the same demographics. And we found that DEMEC was less than 1%, our DESEC was 12%, and PK was 18% rejection. This graphs it out so you can see it visually, but it's important to look at that DEMEC line. It just doesn't budge. That's pretty amazing for a transplant. And our findings have been also substantiated by other people that have reported. Melis's group reported on DEMEC. Multiple groups have reported on DESEC. And you see that there's some reports with decreasing rejection rates, and that may be because the grafts are getting thinner in dissect than they used to be, and that may be the reason. We're just transplanting less stroma. So with immunologic graft rejection, that's the leading cause of failure in PK, and that risk may be related either to the layers of the cornea that we transplant or the number of keratocytes that we transplant. And as dissect gets better, I think we're going to see lower rejection rates. Now, our steroid dosing that we started out with in the past was based on PK, where we tried to balance the risk of an IOP elevation versus the risk of a rejection. If we look at that risk-benefit ratio now for DMEC, it's almost all on the IOP side. We don't have very many rejections, so we should be able to change our steroid dosing. We've done 2 prospective studies where we compared using a prednisolone acetate in one to fluorometholone. These were randomized studies, and this shows the dosing regimen where after a month we switched them to either prednisolone acetate or FML at the same dosing regimen. And we found there were no rejections in the pred arm. We had 1.4% in the fluorometholone arm. And this shows the rejection rate on the left, the IOP increase on the right. And we looked at IOP increase 2 ways, either an absolute pressure over 24 or a pressure 10 millimeters higher than their baseline when we saw them. And there was a significant difference between the 2 groups, as you would probably expect. What you might not expect is the number of eyes that came in for an exam with a pressure over 30 or 40. That was definitely over 30 happened in both groups, so as long as they're on steroids, you need to keep following patients. We've more recently finished up a study comparing prednisolone acetate to lotoprednel gel. The important thing here, no rejections in either group and still a significant difference in pressure elevation. This shows the difference here, and what's important in the lotoprednel group is that the majority of those were people that had preoperative diagnosis of medically treated glaucoma. So we had a few people with glaucoma in each group to start with. And this shows the results once again for those over 10 millimeters of mercury from baseline, over 24, over 30, and over 40. So those do happen. So if you want to summarize these, they've shown that we still have a really low rejection rate in DMEC that's been demonstrated in these studies. We've also changed the way we do our steroid dosing. So 2 months after surgery, we switch our patients either to fluorometholone or lotoprednel gel. That's for Caucasians, mostly what we've had in our study. We showed with dissect that African Americans have 5-fold higher risk of rejection episodes, and so we try to keep them on a higher dose a bit longer. We're doing a new study where we've already enrolled 450 eyes, where we're giving patients the options to go on or off steroids at a year, and we're looking at the relative risk factor for stopping steroids altogether. Now, probably every glaucoma surgery has some sort of long-term effect on the cornea, and that's what I want to talk about now. And I think that our corneal transplants may be the canary in the mine for filtration surgeries. And I think it's important to remember that the type of filter you use today is going to determine how busy corneal surgeons are going to be in the future. So what are the problems with PK and glaucoma? Glaucoma increases the risk of PK failure, and glaucoma is associated with poor PK visual and survival outcomes. When we analyzed PK in our practice, we found there were 3 major causes of failure: endothelial failure with or without a history of rejection, and ocular surface disease. We found that if someone had a pre-existing diagnosis of glaucoma, it doubled the risk of rejection failure and endothelial failure without rejection, and it tripled the risk of surface-related failure. We think that was because of the chronic use of glaucoma drops that have preservatives in them that cause a cumulative toxic effect and chronic inflammation. The corneal donor study found that there was twice the risk of failure if people had a history of medically managed glaucoma, triple the risk if they were treated with surgery, and 7 times the risk if they had both surgery and medically managed. So there's a real problem with glaucoma and PK. Now, EK removes a lot of these confounding variables. We don't have the ocular surface disease because we don't have an anesthetic cornea, and we also don't have problems with sutures, and there's no angle compression. So how does EK compare in these areas? Well, we did a study where we looked at IOP elevation 1 year, for the 1 year after dissect. We looked at the relative risk once again for over 24 millimeters of mercury or 10 above baseline. We found that in the control group that had no preoperative glaucoma, that about 35% developed a high pressure within a year, and this is at the higher dosing that we used to use for our PKs, for prednisolone acetate. If we decreased the steroid dosing in those patients, because of a high pressure, it doubled their risk of a rejection episode. And this shows the relative risk for a high pressure, 35% for control, medically managed 45%, and glaucoma with surgery 43%. Visual recovery was excellent, whether they had glaucoma or not, and even if they had glaucoma surgery, they had excellent visual recovery at a year. So DESEC can significantly improve vision in glaucoma patients that have decompensation, but you have to follow them for the pressure. What about survival? Well, ocular surface disease is eliminated because we don't have the anesthetic cornea. And we looked at survival rates for our Fuchs patients, and they were the same whether they had DESEC or PK at 5 years. But we had a big decrease in the DESEC group at 5 years relative to PK. We went back and looked at the pseudophakic cases, and we found that in our earlier PK series, only 3% had had a filter, whereas in our DESEC series, a third had. And that's becoming an increasing reason for transplants in our country. Then if we look at the 5-year survival rate, we find there's no difference in survival for DESEC grafts, whether they have medically managed or not. But if they've had a TRAB, their survival rate at 5 years drops down to 59%, or prior shunt drops down to 25%. It's even more marked if it's a DESEC under a failed PK. The only risk factor for a graft failure in a DESEC under PK wasn't the number of grafts they'd had before, but whether they had a tube. At 4 years, only 22% survived. Tony Aldavi's found similar results, where if they've had a filter, had a much higher failure rate than if they haven't had a filter. So why do filters hurt grafts? In 2011, we reported where we looked at anterior chamber fluid, and we found an increased protein content. And we postulated that there's something about the proteins. Perhaps they're pro-inflammatory, perhaps they cause apoptosis, but something's not right with that extra protein. We've more recently looked at a variety of different types of filters and found that the tubes were by far the worst, and express shunt and TRABs were better. And so we're not really sure what's going on. Maybe we're just polluting the environment of the anterior chamber with all of these proteins. So I think grafts are the canary in the mine, and I think that if we're seeing these grafts fail quicker, we're going to see normal corneas fail quicker too with tubes, and that's a real concern I have for the future. So let's look at these 7 givens that we had in 2005 and how they've changed. I think now we can say Goutte decreased vision. You don't do your Fuchs patients a favor by only doing phaco without removing the Goutte. You don't need to wait a year between eyes if you're doing DEMEC. Older donors are better than young ones for DEMEC. That's a big change. I think people had a hard time believing that at first. Stromal tissue is important for immune recognition. I don't think we really appreciated that before. You can get great vision for eyes with glaucoma if you do EK, and tubes are definitely worse than TRABs for the cornea. They have poorer survival rates, and there's more intense changes in the anterior chamber protein. So what's the future hold? I think we may be ordering cultured cells, maybe from Japan in a syringe, and it'll be an in-office procedure. We'll be fighting with the optometrist for who gets to do that. Topical drops will be used to stimulate regrowth of endothelial cells and pseudophakic endothelial decompensation. What's going to be the future challenge at the World Corneal Congress in 2025? This is a prediction. I think the most common cause of corneal decomp will be tubes, and we'll be figuring out what to do with that, because if the tubes last 5 years or less, or the grafts last 5 years or less with a tube, that means we're going to be doing a lot of repeat grafts. And we're going to have to figure out how to handle that. So my dream for endothelial keratoplasty is that DEMECs will be able to be done all over the world, including the third world for corneal decompensation. We'll be able to give them some type of depot, either subconj or perhaps in the eye. It'll last for 2 to 6 months, and they'll just come back at 2 to 6 months. We'll have to work out what dosing works without causing a steroid-induced increase in pressure. So in summary, EK is amazing. We get improved vision, improved safety, decreased rejections, decreased use of steroids and high pressures, and an improved understanding of cornea and glaucoma. Thank you.